People often ask why it isn't easier to get hold of donor eggs and donor sperm in Australia, and it is something that drives us nuts because there are so many people who need donor sperm, there's so many people that need donor eggs. The reality is it's about the rules that we have in Australia, the legal framework for being a donor in Australia. And overseas, donors are allowed to be paid, are allowed to receive money for donating, so there's commercial donations allowed, and so it's very easy for people to rock up and be paid for sperm donation. And overseas in Greece and South Africa and other countries, Argentina for example, people get paid well to donate their eggs, but in Australia it's illegal to do that, and so the use of donor sperm and donor eggs can really only be from those people who do it out of the goodness of their hearts, which is fabulous. But as you can imagine, it's much harder to get people to do this kind of thing if they're not going to be reimbursed. Of course, you are allowed to be reimbursed. You're allowed to be reimbursed for your time and so on, and attending appointments, and of course if you secure yourself an egg donor, then one always pays for that egg donor to go through treatment. But we don't have big banks of egg donors. It just doesn't work like that because there's no money involved. Sadly, I wish there was a greater focus on getting people to be a donor, getting people to be donors, and getting people to realise what a great thing it is to be a donor. But there's not, and for that reason it is harder to get hold of donor material in Australia and New Zealand. So adenomyosis is actually really common, and if you look at the hysterectomy specimens, which I know is not what people are really thinking about, but if you looked at hysterectomy specimens from women in their 70s, for example, you'd find that more women would actually have adenomyosis than wouldn't. Okay, so it's something that is really very common. It's found in women particularly as they age. It may be associated with endometriosis, which is something that's far more common. Essentially what it is, or the way I like to think of it, is where the cells that usually line the endometrial cells that usually line the inner part of the endometrial cavity can sometimes find themselves in the walls of the uterus. So these cells that usually line the inner part of the endometrial cavity, which are usually shed out each month, can burrow into the walls of the uterus, into the muscle wall, and that can create quite a thick and boggy and tender uterus, and a uterus that is often associated with painful and heavy periods. The frustrating part about adenomyosis is that adenomyosis can't really be treated. I mean, you can't cut it out because of course it's in the muscle wall, and if you cut that out then you're removing a big hunk out of the uterus. So largely there are some unusual circumstances where you've got quite defined small areas of adenomyosis that can be cut out, but by and large it's not something that can be cut out. And so for people who have this, the question is, does it affect their fertility? It might. It can have an effect on fertility, but it's so hard to know without knowing all the other things about a woman and a couple whether adenomyosis is actually relevant, because of course if you're someone who's 41 years old, not going to have very many eggs, potentially the egg quality is poor. Is that likely to be the problem, or is adenomyosis going to be the problem? Well, it's probably going to be the egg quality. If there's a major sperm problem, of course, that's more likely. So you can have a bit of adenomyosis, but it actually be quite irrelevant when it comes to your fertility. Now, that's not the case for everybody, because there are going to be some women who do have significant adenomyosis where it really does play a role. So, and you might know that if you have significant symptoms. You might have an ultrasound or an MRI scan that shows adenomyosis, and there may be no other obvious reason for your infertility. Okay, and in that situation there is a treatment that does have some benefit in terms of IVF. Usually people in that situation would have already started going down the IVF path, often have had a number of embryos put back, and they might have failure of implantation. And in that situation, occasionally what we do is we actually downregulate people's hypothalamic pituitary ovarian axis. So what that means is we put them on something often called Zoladex, which is an injection that goes in the abdominal wall. And what that does is put the ovaries to sleep, and we put the ovaries to sleep for a few months before then doing an embryo transfer. So in doing that, we quieten down, we put the adenomyosis to sleep, in essence, before we do the embryo transfer. And that can often help in those situations where we think adenomyosis is playing a significant role. It's not uncommon for people to struggle to conceive their second child, and they might have had no problems with the first one, and second time round something has happened that makes it more tricky for them to conceive. Now that thing might have been there at the very beginning when they conceived their first child, and the first child might have just been lucky. But often things can change in a woman or a man's life that does alter their fertility second time around. A common thing might be that your cycles become more irregular, and that can be for a number of reasons, and I won't go into those exact reasons, but a common one is something like polycystic ovarian syndrome. Often if somebody has normal cycles and then puts on some weight, maybe related to having a child, maybe puts on 10 kilos or 15 kilos, a significant amount of weight, they might notice that their cycles go from being very regular to maybe being less regular. Now there are other causes, things like thyroid dysfunction, the pituitary gland in the brain can sometimes give off hormones that might make cycles irregular. So there are a number of things that can be the cause, but the important thing if your cycles are irregular is to realise that when your cycles are irregular, it means your ovulation isn't happening at the same time each month. And so you know if you're ovulating because you might get ovulation pain, you might get change in cervical mucus, those things are key signs of ovulation. But the main thing about ovulation, if it's happening at exactly the same time each month, your cycles are going to be totally regular. 28, 30 days, 32 days, whatever it is, if they come at about the same time each month, you know you're ovulating. Whereas if you're trying for a baby, say baby number 2, and your cycles have become prolonged or irregular, so they might be 26 days, one month, so that's probably a good ovulation cycle, but the next one's 42, that ovulation is clearly happening at a different time or not happening at all. So if that's the situation, then clearly something has happened that has altered your ovulation and is meaning that you're either not ovulating or ovulating only intermittently, but at a time that's irregular and really hard for you to track down. And that makes it really hard to conceive. It doesn't make it impossible, it does make it a lot more tricky. In that kind of situation, often you'll see your GP. Your GP might have done some bloods, and the bloods may look quite normal. But it's very hard to interpret bloods like that unless they are done in keeping with what your cycles is doing. So in general, if this kind of thing happens, I'd strongly recommend you see your GP for a referral to a specialist. As a specialist, what would happen is we'd see you, often we'd track your cycle, so get you to do bloods on a number of different occasions throughout the cycle, perhaps marry that up with a scan, so we can say, hey look, there's an egg, it looks like it's going to ovulate, see if that matches what your blood test shows, and be able to track and say, hey listen, have sex now, or hey look, you're not ovulating, and there's obviously a reason why, and we send you off for some bloods, often looking at things like your male hormone levels, prolactin hormones, thyroid hormones, and of course confirmation that you're ovulating. So there are a number of investigations, but definitely in that situation where maybe you've been trying for 6 or 7 months, your cycle's all out of whack, definitely it's worth talking to your specialist at that point to get some further advice. PCOS, or polycystic ovarian syndrome, is one of these really frustrating conditions where if you start Googling it, you're going to find a world of advice. You're going to find a world of different diets, people telling you to avoid different things, different type of exercise regimes, and of course all of the different medical treatments, clomiphene, letrozole, injections, IVF, ovarian drilling. There's a world of information out there about PCOS. What I would urge people who are have PCOS or reading about polycystic ovarian syndrome to realise is that despite all of the things that are claimed by different websites, there is not one diet that's the best diet. There's not one food type to avoid or one food type that is better than other food types. You can't make PCOS go away. This is a complex syndrome with some genetic and some environmental factors. You can't just take a tablet that's going to make PCOS go away. Starting on a carbohydrate-free diet or a lactose-free diet, that's not going to suddenly make your PCOS better. What is important though is the general principles behind your lifestyle. So we know that polycystic ovarian syndrome for many women, not all women, but many women, is strongly related to their weight, and that keeping your weight in the optimal BMI range between a BMI of 18.5 and about 25. If your BMI is within that range, then it is highly likely that you're going to maximize your chance of ovulating spontaneously. Okay, so definitely if you've got a BMI of 34, for example, then going on a healthy diet that promotes weight loss to try to get your BMI into the normal range is the right thing to do. Now, I wouldn't say there's one diet that's better than any other, but a healthy diet, lots of antioxidants, and obviously a healthy level of exercise, so you've got gradual weight loss that's heading in the right direction, is the best kind of thing. Not keto dieting, okay? You don't want to be doing that, because actually when you're trying to conceive, being in that starvation state, that ketoacidotic state, is not actually healthy for conceiving, so I'd avoid that kind of diet. But any diet that promotes healthy, stable weight loss that you can consistently continue once you finish that, once you conceive, is probably the best kind of diet. So what I would urge people to have a look at is the Jean Hale's website, Jean Hale's, that has the national guidelines and probably the very best patient information that you can find about weight and just general guidance about how best to manage polycystic ovarian syndrome. When you're thinking about conceiving, obviously there's a bunch of things that you are going to want to do, and those things range from making yourself as healthy as you can possibly be, and some of those things are taking vitamins prior to conceiving, and so the key one is folic acid. For anything from sort of 1 to 3 months prior to conceiving, strongly recommend everybody go on some folic acid. That can be in the form of just a single tablet that just has folate or folic acid in it. A lot of the brands, Blackmore's, Elevate, make a complex multivitamin that have iron and iodine and a whole bunch of other trace minerals in them. They're good, and certainly if you have a diet that's you think is deficient in any of those things, then I recommend using one of those kind of multivitamins. But the truth is they're more expensive, they constipate you a little bit more, so really, folic acid's the thing you need. The other ones are more expensive, and I'd say personally I'd just have a diet that's high in antioxidants, and good healthy diet's the way to go, and take some folic acid as an addition. In addition to the standard things like the folic acid that I've just talked about, there is some limited evidence about vitamins that might improve egg health. Now, obviously, that is the absolute holy grail of fertility, is to make eggs younger and make better embryos, and be able to just take a simple tablet that'll suddenly help you with getting pregnant. Now, such a thing doesn't exist, but there's a lot of talk about a thing called CoQ10 or coenzyme Q10. So for all those people that ask me, is there something that you can take that'll give you healthier eggs? Probably the answer is, at this stage, we don't know, but coenzyme Q10 is probably the forerunner in terms of information about things that might improve egg health. So it is something that I say to people, listen, take it. As far as we know, it doesn't do any harm. It obviously costs you some money, but it may have some role in improving egg health. So we see lots and lots and lots of people before they get pregnant, okay? We, not just in the setting of infertility or couples that have been trying, or single people that have been trying, but also people who are considering babies in the future, and just really want to talk about what they should do. Are there things they should worry about? Are there any warning signs with respect to their fertility? And I think it's a really good idea, because it's really important for a lot of people. They want to have babies in the future, but they're just anxious that they get it right, and they screen themselves for things that might cause them a problem with conceiving in the future. So I think it's really sensible, and don't feel crazy if that's what you want to do and ask your GP about or see a specialist about. So I think the things that we would always do as a specialist in that situation is find out about someone's health, what their medical problems are. Do they have high blood pressure that needs to be managed because there's some medications that aren't consistent with being able to conceive? Do they have diabetes? Does that need to be better managed? Kidney disease, things like that that can affect not only your fertility but also the pregnancy journey that hopefully you'll have in the future. You also want to make sure that when you're considering conceiving in the future that things like your cervical screening test are up to date, you don't have any abnormalities with that. And when you do speak to a specialist about this kind of thing, they will always send off a raft of tests that look at things ranging from your blood count, screening for things like thalassemia, through to your blood group, looking at whether you have any funny antibodies in your blood, checking your thyroid, making sure you don't have any infections, things like chlamydia and gonorrhea, and of course making sure that you're up to date with all of your vaccinations. So COVID vax being one of them, but also rubella and also chickenpox vaccine. So we really want to make sure that you're as healthy as you can be before you start, and that any medical problems you have are improved. Obviously that you're not smoking, and that you're minimising things like alcohol. Certainly smoking is terrible for eggs, so anyone thinking about having a baby, please stop smoking because it's a disaster for your eggs, as well as your general health, of course. So I think in that situation we would advise start some folic acid because it's a good thing depending on exactly when you're going to conceive. Make sure that you've got your weight as good as it can be. Get yourself on a good healthy diet to make sure that you're as healthy as you can be when you conceive. The final thing we'd always talk about is we'd do a scan, have a look at someone's pelvis and make sure there was nothing obvious that stood out that would alert us to a condition that might delay conception, and one of those things might be, for example, swollen tubes from a previous infection, maybe a chlamydia or pelvic inflammatory disease that a woman didn't know about, big fibroids in the pelvis, things like endometriosis, these kind of things that might be red flags that wouldn't necessarily stop someone getting pregnant, but are things that you'd really like to know about before you started, because of course if you started trying to conceive and then you discovered that in fact you had some quite significant pelvic abnormality or something that might get in the way of you conceiving, you kind of wish you'd known before. So we'd always strongly recommend having that chat, doing a scan, doing those sort of blood tests just to check. The final test would probably be an AMH test. Many people know about it. It's the egg timer test or ovarian reserve test. It stands for anti-Müllerian hormone, AMH, anti-Müllerian hormone. Costs about $85, so it's not super expensive. Unfortunately, Medicare doesn't pay for any of it, but it's still a very worthwhile test to look at how many eggs you've got. And this doesn't mean the quality, because you can't ever find that out, but how many. And we can compare a woman at any age, their egg count, to other people of the same age. And we'll be able to say, hey, listen, you've got a normal number of eggs, hopefully you're healthy, you're of an age that we think you don't need to jump in and have babies yet, hey, you're all good, go away, think about it, go try to conceive in a few years' time or whatever the plan is. But of course, if we discover that there's major pathology, we discover an egg count that might be really low, unexpectedly low, or something that we think is going to get in the way of conceiving, that's something you definitely want to definitely would want to know before you did start trying, because it might alter when you start trying, potentially how you start trying, and whether or not any other tests need to be undertaken.